started with this webinar, and then I would like to introduce the first speaker, Dr. Monsi Aman from Brunei. He is a consultant of cardiologist, Department of Cardiology, Ripas Hospital, a physician consultant cardiologist, Jerome Park Medical Center, adjunct associate professor at the Institute of the Health Sciences of the University from Brunei. And then he'll talk about the optimal daily step count and step cadence to reduce cardiovascular event and all-cause mortality and its result or not. Please, to you, Dr. Monsi, about 20-minute presentation. Thank you very much.
Share this one. Can you all hear me?
Yes, Doctor. This is very clear.
Okay. So let me first thanks the APSC and the director, chairpersons for inviting me for joining this webinar on sports in cardiovascular health, a double-edged sword or not. I am interested to talk on the optimal daily step counts and the step cadence to reduce cardiovascular events and all-cause mortality. What is a threshold and is there any NIDA? So as we know that cardiovascular disease is the leading cause of global morbidity and mortality, and low levels of physical activity is a leading independent predictor of poor health associated with increased prevalence of the factors that predispose to cardiovascular development. Sports, exercise, and physical activity are part of all current recommendations for the prevention of the cardiovascular disease, which are included in the recent ESC, WHO, and American Heart Association recommendations. The epidemiological evidence for the beneficial effect of the physical activity is indeed overwhelming. Even simple body movements, such as standing or sitting up and down, appear to be a protective mechanism compared to just sitting alone. So what are the general recommendations for exercise and sports according to the ESC 2020 guidelines in healthy individuals? So as I will be talking particularly, what are the recommendations for the optimum exercise in healthy individuals? So as per the recommendations of the ESC 2020 guidelines, at least 150 minutes per week of moderate intensity or 75 minutes per week of vigorous activity, aerobic exercise, or an equivalent combination, therefore, is recommended in all healthy adults. A gradual increase in aerobic exercise to 300 minutes per week of moderate intensity or 150 minutes per week of vigorous intensity aerobic exercise or equivalent combination is recommended for additional benefits in healthy adults. These are all class 1 recommendations according to the ESC. So what are the recommendations according to WHO? WHO organization, World Health Heart Organization, physical activity guidelines suggest the people should engage in at least 150 to 300 minutes of moderate intensity physical activity or 75 to 150 minutes of vigorous intensity each week. So this ESC and the WHO is almost the same. They are expressing on the number of minutes. However, daily step count have been used as a popular approach to provide a relatively simple physical activity targets for the general public. The minimal optimal daily step count for health improvements is still, it is unclear. So just to say, guideline to say for the, what is mean by the moderate intensity activity and what is vigorous intensity activity. Any activity which is more than 150 minutes per week, just like brisk walking, more than 3 miles per hour, bicycling less than 10 miles, water aerobics, tennis, boulder dancing, these are considered as moderate intensity, whereas vigorous intensity, just uphill walking, race walking, bicycling more than 10 miles, running or jogging, tennis, or aerobic dancing is considered as a vigorous intensity. Now, coming to our step counting, which has been long been used as a method of measuring distance. Starting in the mid-1900s, researchers began using the steps per count to quantify ambulatory physical activity. This line of research gained momentum after 1920 with the introduction of reasonably accurate spring-levered pedometrics with a digital displays. Steps have several advantages. So the step counting has several advantages as a metric for assessing the activity. Easy to measure, objective, and they represent a fundamental unit of human ambulatory activity. This is just to show a digital pedometer, which is measures this electromechanical device which counts the number of steps taken in a given time. The accelerometer also is a kind of pedometer that also tracks the speed and distance that measures. What is the optimum daily step count for cardiovascular disease risk reduction is still debated. To examine a dose-response association between the step count and clinical outcomes, a systematic review of the analysis studies that quantified a daily step count. When I reviewed the literature, I could see at least about three major meta-analysis studies which have come in the Journal of American College of Cardiology, Lancet, and Preventive Cardiology of European Society of Cardiology. So I will just highlight on these three meta-analysis studies. The background of that study, one is the minimal optimal daily step count for health improvement remains unclear. So the first meta-analysis which I have described is about a systematic review of about 12 studies which has come up, and the relationship between the volume of daily step counts, which reduces the mortality, and the general population in the general population, of which 60% are women, and this has been studied in association with the sex as well as the cadence steps and the location of the measuring device, which the primary outcome included the what's called mortality and daily step count intensity and objective step measuring mortality. In this, the age has been taken as more than 18 years without cardiovascular disease at baseline. So this picture shows what is the optimum step counts along with this the minimum dose. So which shows that as a gradual increase in these step counts, there is a reduction in the mortality in the as well as in the incidence of cardiovascular disease. Now, what are the results? So from this study, we can see that there are no significant difference between men and women. Compared to the low step count group reaching about 2000, a study found a minimum of 2,517 steps is associated with an 8% reduction in all-cause mortality, as well as about more than 2,700 steps per day for an 11% reduction in the cardiovascular risk. The optimum volume of 8,763 steps per day resulted in a 60% reduction in the all-cause mortality and a step of about 7,126 steps per day for a 51% reduction in the incidence of cardiovascular disease. So the general results shows that the risk reduction is found to be higher when the hip-1 accelerometers are used compared to the wrist-1 accelerometers, likely due to the approximation of the oximeter being measured. However, the minimal and optimal steps of the benefit were not significant for the location. The continuous dose-response analysis revealed a new non-linear relationship between association between step count and all-cause mortality. The risk reductions become statistically significant for the assessment of reduction of mortality of cardiovascular disease at 2,517 steps for reducing the cardiovascular mortality and 2,700 for the cardiovascular events respectively. Further increase in the step count are associated with decrease in cardiovascular mortality and cardiovascular risk until the steps of about 8,763 and 7,123 steps respectively, with additional reduction in the mortality and incident cardiovascular disease, which are not statistically significant. The optimum dose is defined as the maximum risk reduction. Therefore, is established as 8,763 steps for an all-cause mortality and 7,100 steps for an incident of cardiovascular disease. So the optimal step count observed was about 8,800 in the study and 7,200 for the incident cardiovascular disease. Step counts beyond our optimum dose minimally improved outcome. The plate that suggests that most benefits are observed at step counts less than 10,000 steps per day, which aligns with the observation recent meta-analysis. Although step volumes beyond this level are not associated additional health benefits, there is no reason to discourage individuals from such behavior, as such is highly physically active may provide other benefits such as the joy, improved quality, and a better sleep and mental health. So the minimum step count needed to elicit significant benefits were about 2,600 steps per day for all-cause mortality and 2,800 steps for incident cardiovascular disease. In comparison, individuals accumulated 2,000. Increase of 1,000 steps, they associate additional health benefit, especially among those with a low number of basal steps, highlighting that every step counts. So what about the step cadence? Intermediate, that is about 63 steps per minute or high, more than this one, a cadence or associated with a lower mortality risk than a low cadence of about median of 29 steps per minute daily. The findings underline that both volume as well as the intensity are independently associated with the health and their risk reductions. Step volumes at a higher step cadence have a greater proportion of reduction in the physical activity relative to the total additional benefit compared to the low cadence. Reductions in the mortality and cardiovascular risk are larger for hip accelerators than pedometers at rest-on accelerators. Hip-mounted devices potentially are more likely to accurately measure steps given the close proximity of the locomotor or acceleration. So that is the conclusion of this slide. Minimum dose of 2,517 and 2,735 steps are associated with all-cause reduction in the mortality and 11% in cardiovascular risk respectively. Optimum doses found to be 8,763 steps for all-cause mortality and 7,102 steps for incident of cardiovascular disease. Increasing from low to intermediate, the high cadence are also associated with decreased cardiovascular mortality, 33%, 28% reductions after adjustment with the daily step count. Risk reductions were greater for hip-on accelerometers than for the wrist-on accelerometers. There were no important differences between risk reduction and step count between men and women. So what is our perceptive, which has been described in the JAC? Clinician can use these findings, study the perceptive, prescribe optimum physical step count in patients using the step count devices. The volume of steps per day and intensity of cadence were independently with risk reductions, although higher step counts beyond 10,000 were also associated with additional health benefits. Another one is the world supposed to be the world's largest study about this is come up in the European Journal of Preventive Cardiology. That's saying that more you walk, lower is risk of death, even if it is more than 10,000. So that was an analysis of about more than 200,000, that is 226,800 people from 17 different studies. Showed that greater the health, the risk of dying from cause from cardiovascular disease significantly improves with every 500 to 1,000 extra steps you walk. An increase of 1,000 steps per day associated with a 15% reduction in the risk of dying from any cause. An increase of 500 steps associated with 7% reduction in dying. So this study was led by Professor Banang, the professor of cardiology. Even if people walked as many as 20,000 steps per day, the health benefits continue to increase. They found that there is no upper limit. So still there is a doubt. So the study that is published in the European Journal of Preventive Cardiology found that walking at least 3,861 steps a day reduces the risk of dying from the cause. Now this is another study, which is also a major study which are found in Lancet, which is about 12 unpublished studies as well as 5 published studies, where they say that about 47,471 participants, the mean age was 65 years, and about 68 are females. So there they say the adults younger than 68 years have a significantly higher median that compared to the people with older than 60 years. So they say that there is a non-linear dose-response association between the all-cause mortality and the lowest heart rate was observed between 7,000 to 9,000 steps in overall sample. And this chart shows that there is a dose-response association between step counts per day and all-cause mortality by age group, which shows a progressive decreased risk of mortality among adults aged 60 years and older, with increasing number of steps per day until 6,000 steps per day, and among adults younger than 60 years, they say until up to 8,000 to 10,000 steps. So there is a difference in the age in this study now. So the number of daily steps at which the mortality plateaus aged 60 years and older was approximately 6,000 to 8,000 per day among adults younger than 60 years and approximately 8,000 to 10,000 steps per day for these younger people. Now coming to our topic of exercise, the double-edged sword for endothelial function. How exercise will affect whether the mild intensity or a moderate intensity or high intensity on the endothelial function, which helps for the reducing cardiovascular mortality and cardiovascular events. So I have gone through this research study, which shows that the production of nitric oxide and reactive oxygen species in response to different exercise intensities. During mild intensity exercise, the nitric oxide and reactive oxygen are constant, resulting in no change in the endothelial function. Whereas the production of nitric oxide and reactive oxygen were greater during moderate intensity than during mild intensity. During moderate intensity exercise, the production of nitric oxide is greater than the production of reactive oxygen, resulting in augmentation of endothelial function. Production of nitric oxide and that of reactive oxygen are greater during high intensity exercise than during moderate intensity exercise. During high intensity exercise, the production of the reactive oxygen species is greater than the production of nitrous oxide, resulting in reduced endothelial function. So, not all types of exercise improve endothelial function. Clinically important to select appropriate intensity, duration, and frequency and kind of exercise, as high intensity can be hazardous to human vessels. This slide also shows that the gradual increase in exercise increases the or reduces the cardiovascular mortality. By the time it increases, it decreases the cardiovascular, increases the cardiovascular mortality. So, what are my quick steps? Optimum daily steps to count to reduce cardiovascular mortality. A minimum of 2,517 steps per day was associated with a significant reduction of all-cause mortality and 2,700 steps per day to reduction of cardiovascular risk. The optimum volume of 8,763 steps per day resulted in a significant reduction of cardiovascular mortality and risk reduction incident of cardiovascular disease. The volume, the steps per day, and the intensity, that is the cadence of the steps, were independently associated with all-cause cardiovascular reductions. However, volume more than 10,000 steps have a plateau effect with no significant additional cardiovascular risk benefit. This concludes my presentation. Thank you.
Yeah, thank
Over
you
to
very
the
much.
chairpersons.
Okay, thank you very much, Dr. Oman. It's very interesting presentation from you. I think that I think a lot of question for this one. And then first, I would like to ask you about, you suggest that we should walk at least 2,500 steps, at least that to reduce the mortality. And then it is ideally that we can walk till 8,000 or to reduce the mortality till 50%, 60%. It's very interesting. Is there any difference between, I mean that, Asian people for us, like us here in the step to reduce the mortality or incident of coronary disease, for example, cardiovascular disease? Is there any study for that?
I could not see any difference, or I didn't see any specific study between Asians, Europeans, or I don't know. I have not come across. I have reviewed a lot of literature on this. I could not see any independent studies particular to Asians compared to Europeans or other groups now. This basically there's studies on general population.
Yes.
Yeah. You have
I think I'm agree with you.
Yeah.
No, I think that I have agree with you because there is no ethnicity difference, especially for this one. And then I think that the use of pedometer is very important, especially in your country. It is usual to use a pedometer for the people to have a lot of step.
Yeah, I think people are using, because when you walk on this corridors, we see the people binding on the either on the wrist or in this ankle area. I have seen many people using, but I usually use the smartphones now. Our Apple Watch is equally good for measuring the steps and the calorie consumption all now.
Yes, I am agree with you because a lot of device that we can use to help us to count the step, and then of course that is to reduce the cardiovascular risk, especially about the mortality. It is very interesting that you explain about the high intensity and then with the moderate intensity. I think I'll talk about that later, especially in atherosclerosis. Is there any suggestion from you for our patients, especially with cardiovascular disease? Is that, for example, that some of our patients or some of the people use the high interval intensity training, which is that they use the moderate intensity, high intensity, and then etc. Is that any difference? I mean that from your presentation, of course, that the moderate intensity is better than figures or very high intensity, of course.
So based on the mechanism, what they are postulating about the endothelial function, so as the intensity of exercise increases, what they are saying about 10,000 steps, it is not good for the endothelial function, no?
Yeah.
So
Yes.
long-term, high-intensity exercises, I think it may be not a good idea based on the evidence which is available. So it may have some improvement in our general ability, but long-term high-intensity exercises, what in our clinical experience also was found to be not good. It has seen so-called produces the athlete's heart, and yeah. So that is my suggestion is high intensity exercise, prolonged high intensity exercise is not advisable.
Yeah. Okay. Thank you much.
Okay.
Okay. Okay. Thank you very much. I'm sorry because of technical problem. Thank you very much, Dr. Monsi from Brunei. I think that's very interesting presentation from you. And then I think that's for the next, we will have Dr. Galaza Irfan from Pakistan. She is an associate professor and then cardiac electrophysiology, National Institute of Cardiovascular Diseases in Karachi, Pakistan. And then Dr. Galaza will talk about the long-term laser time physical activity and safety to reduce the cardiac and the cardiovascular and all-cause mortality and threshold or nadir. For you, please, 20 minutes, Dr. Galaza.
Thank you. First, I would like to thank the APSC forum for giving me the opportunity to present on this topic. It is, I think, a very important topic because the cardiovascular is just moving towards the more and more towards the prevention. I'm just changing it to the presentation mode. I hope you people can see it.
Okay, we can see it. Maybe, yes, that's great.
Okay.
Yeah, please, yes.
Okay, so the topic given to me is long-term leisure time physical activity intensity to reduce cardiovascular and all-cause mortality. Any threshold or neither. I think I will just, my presentation will be a continuation of what we are speaking in the morning. Dr. Omne has put a lot of good background for my presentation, I would say, with a lot of things. So I'm just going to share a little bit more new data regarding the leisure time physical activity. So first, if we see the physical activity, the physical activity is a modifiable factors in preventing, treating cardiometabolic disease. Leisure time physical activities are those physical activities that are not required as essential activities of daily living and are performed at the discretion of the person. And it usually involves conscious planning, self-control time, and sufficient recovery. In contrast to that, if we see occupational physical activity, which operates independent of socioeconomic aspects of the occupations, and occupation-based physical activity is primarily determined by the occupational tasks beyond workers' control. As we have already talked in the morning about the various benefits of the exercise, physical activity, starting with the cognitive function improvement, decrease risk of a stroke, decrease anxiety, decrease dementia incidence. And if we see the cardiovascular effects, it decreases mortality, decreases coronary artery disease by decreasing myocardial oxygen demand, coronary flow, endothelial dysfunctions, increased nitrous oxide, then anti-atherosclerotic effect of increased HDL, decreased LDL, decreased adiposity, increased insulin sensitivity, and decreases inflammation. At the same time, with anti-atherosclerotic effect, antithrombotic effects of decreased platelet adhesiveness, and decreased blood viscosity, all leads to improved cardiovascular morbidity and mortality, and decreasing weight loss, helping in weight loss, and decreasing in not only decreasing the incidence of diabetes, but also improving the outcome in diabetic patients. So these are varied effect of the physical activity. So how much physical activity one should be doing it? With 2022 American Heart Association recommendation, they recommended that adults with 18 to 64 years of age, moderate intensity, at least 150 minutes, and vigorous intensity of 75 per minute, with at least 2 days of exercise, of the different high intensity exercise, and most important, sit less and move more throughout the day. For the age group greater than 65 years, aerobic activities, moderate intensity, at least 150 per minute, or vigorous intensity, at least 75 minutes. Along with that, different muscle strengthening activities, at least 2 days, and other activities, sit less, move more throughout the day, multi-component exercise and balance training, and considering the level of fitness and ability to perform physical activity safely. So moderate intensity aerobic exercise includes brisk walking, recreational swimming, slow bicycling, and vigorous intensity include jogging, running, swimming laps, bicycling, greater than 16 km per hour, and tennis of the singles. ESC 2020 guideline class 1 recommendation is 150 per minute of moderate intensity and 75 per week of vigorous intensity. And it recommends gradual increase in aerobic exercise to 300 minutes per week of moderate intensity, or 150 minutes per week of vigorous intensity aerobic exercise. And multiple sessions of exercise spread throughout the week, that is 4 to 5 days a week, is preferable. Every day of the week are recommended. Just keep in the mind that we are talking about two modes of exercise. One is the moderate intensity and other is the vigorous intensity. Why? Because if we see the benefit of physical activity on with health risk, it is a kind of curvy linear response. That means that at the middle, when the person when a person start exercising, it has the highest benefit of the health. But later on, with the increased physical activity, they actually reach a plateau phase. So after that plateau phase, if they increase the amount of the exercise, or if they increase the intensity of the exercise, they are not getting any more benefit after that. I would like to discuss a paper which is recently published by Harvard Public Health by Dong Lee Group. And in that, they have actually assessed 62,000 people from two large prospective US cohorts. And then in them, they have detailed self-reported leisure time physical activity was assessed with a validated questionnaire, and it was repeated up to 15 times during a follow-up period. And if you see the results here, it's all-cause mortality with the physical activity. With the physical activity, if you see with the moderate physical activity and vigorous physical activity. So there is a plateau phase with both moderate physical activity and with vigorous physical activity. Same goes for non-cardiovascular disease mortality. But if you see the cardiovascular disease mortality with vigorous physical activity, the plateau phase is reached, but you are not getting more mortality benefit as compared to the moderate physical activity. So the conclusion is nearly maximum association with lower mortality was achieved by performing 150 to 300 minutes per week of long-term leisure time, vigorous physical activity, 300 to 600 minutes per week of long-term leisure time, moderate physical activity, or equivalent combination of the both. High levels of either long-term leisure time physical activity or moderate did not clearly show further low cause, all-cause cardiovascular disease and non-cardiovascular disease mortality or harm. For individuals who reported less than 300 minutes per minute of walk, long-term leisure time, moderate physical activity, and additional leisure time, vigorous physical activity was associated with lower mortality. But among those who reported greater than 300 minutes per week of long-term leisure time, moderate physical activity, in addition of leisure time activity, vigorous activity, they did not appear to be associated with lower mortality beyond moderate physical activity. So we have until now we have concluded that it's a curvilinear response. So after our time, when you start the exercise, you have get the maximum benefit, but later on you reach a plateau phase. And if you do beyond that plateau phase, what's happening? So the extreme exercise hypothesis is potential maladaptations. It suggests that long-term, high-volume, high-intensity exercise training may induce deleterious cardiac adaptation in some individuals, and over the time with these high-volume intensity exercise training can induce cardiac maladaptations such as increased risk of atrial fibrillation, coronary artery calcification, and myocardial fibrosis. So dose-response relationship, which I have already discussed with you, if we see this curve, it's a curvilinear curve. So when we come with the high, it is the most beneficial point, and when you go with the very high, you have increased risk of atrial fibrillation, coronary artery calcification. So this is the exercise curvilinear response of the very high intensity exercise. And various deleterious effect of the exercise on the heart can cause cardiac dysfunction, atrial fibrillation, aortic dilatation, cardiomyopathy, coronary atherosclerosis, myocardial fibrosis, and even sudden cardiac death. So comparative review of different competitive athletes and their level of and they compared with the people who are their active controls counterparts. They revealed that substantially high prevalence of myocardial fibrosis in athletes, that is 12% versus 1.5%. And if active athletes, that is greater than 2000 minute walk, have a higher prevalence of coronary artery calcification score as compared and coronary plaques if they are compared to the least active athletes, that is who are doing less than 1000 minute walk. But the most I would say the interesting fact is that the plaques, coronary plaques or calcium score in the athletes is a kind of very stable plaques. They are not complex plaques. So complex plaques are usually found in people who actually have other risk factors for cardiovascular disease also, and then they are prone to sudden cardiac death. So atrial fibrillation, common arrhythmia in the general population, association between habitual physical exercise or exercise training and AF is complex, and it is depicted by reverse J-shape curve. Inactivity and insufficient levels of physical activity has been associated with increased risk of AF, whereas meeting the physical activity guidelines lowers the AFib risk. So individuals performing physical activity at upper end of physical activity spectrum, such as endurance athletes, had a 2 to 10-fold higher AFib risk. Primarily, they are driven by volume of lifetime exercise training at a very vigorous intensity. And the potential mechanisms of atrial fibrillation are inflammation, fibrosis, increased vagal tone at rest, regular enhanced sympathetic stimulation during exercise, atrial and ventricular dilatation, hypertrophy, increased stress and shear force, which can lead to vagally mediated shortening the atrial refractory period, atrial stretch, atrial inflammation and scarring, and resulting in atrial fibrillation. And this has same dose response association. If we see here, the people who are doing exercise from 0 to 20 minutes, they are the lower risk of AFib. And the people who are doing exercise from 20 to 50 minutes, they have the equal AFib risk as the people who are not doing it. And high risk is on the people who are doing more than 50 hours per week, they have higher incidence of atrial fibrillation. So in conclusion, every move counts. Being active is significant health benefit for heart rate bodies. Mind whether you're walking, wheeling or cycling, dancing, doing sports, or playing with your kids. Most important, limit sedentary time. Replace with some physical activity. Any is better than none. And 150 per minute per week for pregnant, postpartum women. 150 to 300 per minute per week with adults and older adults, 60 minutes, children, adolescents. On at least 2 days a week, muscle strengthening activities, or at least 3 days a week, multi-component activities for balance and strength. More is better, more than 300 per minute per week, everyone who can do that. Thank you.
Okay, thank you very much, Dr. Galeza, for your presentation. I think that it's very important and very interesting from your presentation about the long-term laser time physical activity. And I would like to ask you about the you in your slide you mentioned about the atrial fibrillation. I think that's very important. Some of the study say that vigorous exercise will induce the atrial fibrillation. Is there any comment for that? Thank you.
Yes. The long-term endurance exercise athletes, they have high chances of atrial fibrillation because of actually what is happening with the exercise. We all know about the athlete's heart. With athlete's heart, what is happening there is fibrosis, number one, because there is a lot of stress, strain on the left atrium, increased volume with the athlete's hearts, and then these increased volume increase the stretching of the left atrium, and actually it will kind of a vicious cycle, which more exercise will more increase the fibrosis and stretching of the left atrium, increase sympathetic activity, will have more triggers, and then these people are more prone to the atrial fibrillation. The new, I would say, things are coming with atrial fibrillation is that, yes, exercise will prevent, but endurance exercise people, they have high risk of atrial fibrillation. In fact, it is being recommended, or there are few studies which have presented that the people who have atrial fibrillation, endurance exercise athletes, they actually ask being to decondition. That means they're being asked to decrease their level of exercise so that they can actually, they have the remodeling which is happening because of the exercise that can be reversed. And it is seen with a lot of endurance exercise patients. I would say that here in Pakistan also we are seeing a lot of these things actually. Previously, people don't know, they are not much into the physical activity, but now we are seeing more and more people involved in physical activities, especially football players or marathon runners. And they have no comorbid conditions, young people, and they are coming with atrial fibrillation. So you just have to ask them to decrease, I would say not stop, but little bit of deconditioning. So from a vigorous exercise mode, they come to the moderate exercise mode, and then actually their incidence or their recurrence of atrial fibrillation decreases a lot.
Okay, thank you very much for your answer, Dr. Ghazala. That's very important. I think I should invite Professor Lee to introduce the next speaker, which is me, myself. I think that I please Professor Lee.
Okay, thank you, Dr. Anpari. And he will be our third speaker of today's webinar. And he's from Department of Cardiology and Vascular Medicine in University Indonesia. And his topic would be impacts of long-term endurance exercise on coronary atherosclerosis and the incident coronary events. Implications from the Master at Heart study. Please, Dr. Anpari.
Okay. Thank you very much, Professor Lee. I think that's this clear enough. My slide. Okay. First of all, thank you very much to Professor Lee.
Sorry, Doctor.
Okay. Yes.
Your slides now is in the not on the full screen. I think
not full screen. It's okay.
yeah, you need
Just a
to click
moment.
use the
Okay.
slideshow. There's a
Yes.
yeah.
Okay. Okay.
You are
Is that
not.
one?
No,
Not
no.
yet. Okay. Just a moment.
Yeah.
Okay. Sorry for that. Okay. Okay, that's okay. Yeah. Yeah. Okay. This one. Nggak apa-apa lah. Okay. That's clear.
Good. Thank you.
Okay. Thank you very much, Professor Lin and Professor Lee, for the introduction. And then this afternoon, I will talk about the impact of long-term endurance exercise on coronary atherosclerosis and incidence of coronary event. This is the implication from the Master Heart study. There is a study which is already published in the ESC journal in 2023. As well as to know that endurance exercise have a good impact, especially in coronary events, especially one of it is as an anti-ischemic effect. As well as to know that endurance exercise will enhance the blood flow and increase the endothelial nitric oxide, increase laminar surface, which is the improved endothelial function. And then it will improve the systemic arterial compliance or elasticity. And then, of course, it will reduce the resistance and afterload. And then due to that, our heart able to pump effectively in long term with a reduction in heart rate, blood pressure, and myocardial oxygen demand during submaximal physical exertion. And then secondly, endurance exercise has effect in antithrombotic effect. With the endurance exercise, it will promote the clot lysis that we call fibrinolysis, autofibrinolysis, by reducing endothelial PA1, and then increasing TPA formation, and then improve endothelial function, and then reduce the platelet aggregation, as well as a number of other factors promoting coagulation, like a fibrinogen, factor 8 and 4, polydobran, etc. And then with the endurance exercise, it will increase the level of anti-inflammatory cytokine. And then this is the psychological cardiac response to endurance exercise training that we see here, that there is a cardiac cellular and molecular remodeling, of course. From that, the previous speakers stated before that it will increase the cardiomyocyte width and length, of course, the hypertrophy, and increase the left ventricle wall thickness, alveolar dilatation. But you know, with the endurance exercise, it will increase the new cardiomyocyte formation due to, and then increase the vessel size and number, and then the contractilities will increase the relaxation, and then the apoptosis of the old cells will happen with the endurance exercise. This is the from a study from Patil in 2012, published in 2012, which is the healthy athlete's heart. With the healthy athlete's heart, actually, that it will be minimal cardiac injury and adequate recovery between exercise, and then of course that it will be improve the cardiac function. But overtrained athletes, of course, it will be more severe cardiac injury, and then of course that this will be inadequate recovery, and then the chronic structural change, reduced cardiac function, and clinical event. This is the randomized clinical trial of 60 male with a CAD to regular vigorous exercise training session with 30 or 60 minutes. And then we see here that the 30-minute physical activity session produce less oxidant stress and augmented arterial elasticity. But a 60 minutes workout will increase the oxidant stress and worsening vascular stiffness, and as assessed by pulse wave velocity. In this study from Swart et al., it is reported that the long-term marathon runners, defined as individuals who have completed at least 25 marathons over past 25 years, show high than expected level of coronary artery calcium and calcified coronary plaque volume. And then in chronic marathons, had significant more calcified plaque if we compare with the CT scan to the sedentary control. And then, of course, that with the endurance exercise, it will be increase the left ventricle mass, typically developed in response of high level of intense long-term exercise training, increase LV mass with correlation with the high calcium score, and then generate protected oxidative stress with a prolonged exercise. This is very interesting study, which is published in a European Heart Journal in 2023 about the master heart study. This is a lifelong endurance exercise and its relation with the coronary arteriosclerosis. This is the objective of the study is investigate the apparent paradox of increased coronary arteriosclerosis among highly trained endurance athletes despite having fewer cardiovascular events. And then the hypothesis, of course, that lifelong endurance exercise and lesser degree late onset training would be associated with lower prevalence of non-calcified and mixed plaque as compared to the inactive, healthy lifestyle without regular endurance training. The study design is this is a prospective cohort study in 3 hospitals, Leuven Hospital, Antwerp Hospital, and then just a hospital herself. And then with the primary endpoint of the current manuscript was investigated cross-sectional design with the CT scan. And then the population of the study is male between 45 and 70 years old. And then the inclusion criteria, of course, that athletes engage in cycling more than 8 hours per week or running more than 6 hours per week, or triathlon training, a combination with the swimming, cycling, and running more than 8 hours per week for at least 6 months prior to baseline. And then non-athlete defined as engaged in less than equal 3 hours per week of physical activity without prior exposure to regular endurance exercise. The exclusion criteria, of course, the medical history of cardiovascular disease, current or past smoker, use anti-diabetic drug, use statin, use antihypertensive drug, body mass index more than 27, and then allergic of iodine contrast agent. Here we see that there is a control, which is the healthy but not athlete, and then late onset endurance athlete is 191, and then lifelong endurance athlete is 191. Of course, the inclusion-exclusion criteria with the primary endpoint prevalence of any coronary plaque, calcified, mixed, or non-calcified by CT scan, and then plaque burden and plaque composition by endurance exercise group. Odds of having coronary plaque in lifelong endurance athletes compared to the control. This is the baseline characteristic. If you see that in the control group, which is that healthy person, the BMI is higher than in a lifelong or late onset athlete. And then the heart rate is lower in lifelong and late onset, and you see here the cholesterol, LDL cholesterol is lesser, and then the HDL cholesterol is better than in the control group. And then this is the exercise characteristic. If you see that VO2 peak of the person in the control is lesser than in the exercise or long life exercise with the athletes, and then or late onset athlete. And then this is the result. I think that it's very interesting about the result. First of all, that calcium score in lifelong endurance population relatively higher than other group, both late onset and control group. And then the other things that we see, the number of plaque of coronary arteries at lifelong endurance population higher than other groups, both late onset and control group. And then this is about the plaque. If you see here that it is patients with a lifelong athlete or late onset athlete, actually they have more than one plaque. And then here that we see prevalence of more than 50% stenosis dominantly by lifelong endurance group, it is with a ratio about 2.7 compared to late onset endurance or non-athletes group. And then prevalence of individual with more than one proximal plaque in lifelong endurance group significantly higher than late onset endurance with the odds ratio of 0.6. Then the most prevalent plaque type in both athletes and non-athletes was calcified plaque, and then followed by mixed and non-calcified plaques. Moreover, a greater proportion of lifelong athletes had plaque of non-calcified and mixed morphology. This is from the result of the Master Hatch study. If you see here's that calcified plaque with more than one proximal plaque is dominantly occupied by individuals in lifelong endurance group, followed by the late onset and control group. And then calcified plaque type more than 50% stenosis remain dominantly occupied by individual with the lifelong endurance group, followed by the control groups and the late onset group, just making a U shape in the graph here. And then non-calcified plaque with more than one proximal plaque is dominantly occupied by individual with lifelong endurance group, and the non-calcified plaque with more than 50% stenosis remain dominantly occupied by the individual in lifelong endurance group. How about the mixed plaque? You see here that the prevalence of mixed plaques type with more than one proximal plaque is and more than 50% stenosis is higher in lifelong endurance athletes. And then what is the explanation actually? First potential explanation for this appearance paradox can be found in this study as vulnerable plaque. Of course, which carry the highest risk of the event, we rare and not associated with the athletic lifestyle. Of course, that in the beginning we said that if you are an athlete with the hypothesis with long life athletes, of course it will reduce the atherosclerosis, but it's different. But of course, that we should know that the dietary habit, actually that the athlete intake high calorie intake and high protein, maybe it's contribute to the coronary atherosclerosis in endurance athlete. And then lifelong and late onset athletes from the Master Hatch study perform more training hours per week and higher metabolic equivalence minute per week with a higher VO2 peak than in other study. And then in non-athlete, actually there is no non-athlete definition here in the study, but actually that they have a higher aerobic capacity than counterfactual study. And then of course, from the data in Master Hatch study, we know that healthy lifestyle and above average cardiorespiratory training and fitness prevent coronary atherosclerosis with a more favorable pattern in more calcified and less mixed or non-calcified plaques. Incremental endurance sport training load and associated increase in fitness do not affect the distribution of plaque type. Lifetime intensity endurance training increase the overall coronary atherosclerotic burden with more plaque, include non-classified and mixed plaque, plaque in proximal segment, and thus with a significant degree stenosis. Here's that this is the study from Patil in 2012, and then it's explained about the dose of physical activity and all-cause mortality reduction. And then the mortality benefit of exercise appear with the even small amount of daily exercise and peak at 50 minutes of vigorous exercise. You should hear that the peak is about the 50% vigorous exercise. This is the relationship between running speed and mortality study from the journal in 2012. It is stated almost it's almost the same with the previous speaker. It is like U-shaped curve, which is that if you run in 7 miles per hour, it's better, reduce the mortality. If you work more than 8 miles per hour or less than 6 minutes per hour. It's mean that moderate intensity is very important, especially to reduce the atherosclerotic. Then in vigorous or very high intensity exercise training. As summary, I think that lifelong endurance sport participation is not associated with more favorable coronary plaque composition compared to the healthy lifestyle. Lifelong endurance athletes had more coronary plaque, including more non-calcified plaque in proximal segment than fit and healthy individual with a similarly low cardiovascular risk profile. The dose-response relationship between endurance training and coronary atherosclerosis may be a reverse G-shape. Longitudinal research is needed to reconcile this finding with the risk of cardiovascular event at the higher end of the endurance exercise spectrum. I think that's all. Thank you very much.
Thank you, Dr. Ambari, for your excellent talk. And I would like to ask if there's any question from audience. No, if not, I have some question for Dr. Ambari.
Okay.
So do you expect this result in your study? I mean, the lifelong endurance exercise, they did have more plaque, no matter it's calcified or non-calcified or mixed plaques. So do you expect this kind of results?
Yeah, of course, in this study, I think it's very important from the previous speaker that we know from Dr. Monid and Dr. Galaza, we know that moderate intensity is very important. In this study, they just make correlations between exercise, the intensity with the coronary, with the atherosclerotic. And then we know from this study that if you perform very high intensity in especially in long life athletes, it will increase the risk of arteriosclerosis, especially the stenosis with the calcified. But how about the mortality? And then how about the cardiovascular risk? Of course, that we should remember in some study, it is stated in an athlete, of course, its survival is better than a sedentary lifestyle. But you should remember in athlete, of course, that the coronary artery is very wide, large, with a stenosis. And then I think in the athlete, of course, the survival is better in even a sedentary. But of course, in this study, it is stated that moderate intensity, like AC guideline stated, about 150 or 300 minutes per week is very important to reduce the risk of atherosclerotic. Maybe the next study is very important. I think in this study we should know maybe of use more follow-up for the patients to know about the reduction, the survival of the patients with the long-term endurance athletes. Yeah. Thank you.
Thank you. So you think that one of the possible mechanism is from their dietary habit? Maybe they
one of the hypothesis. Yeah, what is the difference? Of course, in the athletes, especially in high intensity athlete, they need more calorie, high intake, and then high protein. I think that's in this study. Of course, the limitation is the study is just only for the men, not a woman. And then secondly, there is mostly of the white people here. The ethnicity is you should be careful with the ethnicity. And then the other thing that they don't have a food recall. I think it's very important, especially for increase the risk of atherosclerotic for the patients. Thank you very much.
Right, but in the report they did provide the biochemistry data that's showing there is actually lower LDL cholesterol level and the relatively high HDL cholesterol level. So
yeah.
For these high endurance athletes, they should have lower LDL cholesterol target to prevent artery plaque.
Yes, I'm agree with you, Professor Lee. Thank you.
Okay, thank you. If there is no more question, I would like to move on to the next speaker. We are happy to have Dr. Dim Hun Lim. He's from Vietnam, and he's also a cardiologist from Vietnam National Heart Institute, Bac Mong Hospital. And his talk will be physical activity trajectory to reduce long-term cardiovascular events in patients with coronary artery disease. The pattern matters. Okay, please, Dr. Lim.
Okay. Hello, good afternoon. Can you see my slides? Okay. Hello, Mrs. Chairman. It is my great honor to be here today to participate in very interesting sessions about physical activities and heart disease. It is my disclosure. I don't have any conflict of interest. I'm a interventional cardiologist working in my hospital, and I was trained in Singapore about 10 years ago. But I do have something to disclose that I was a marathon runner. I was trained hard. I ran a 2:41. 2 hours and 40 minutes in the Chicago last October. So I did know about everything that Dr. Mbari have said about, and I know that I might have a higher risk of coronary plaque. But so my point of view might be a little bit biased about long-term endurance training. So let's start with a case study with Mr. Dave McGillivray. He is quite famous. If you go to Google, you go to Wikipedia, you can know about this gentleman. He was an extreme athlete. He has run across the US. He has swam 24 consecutive hours in an indoor pool, finished 7 marathons on 7 continents in 7 days. So you can see that extremely healthy, extremely fit. But in 2013, he had chest pain, and the coronary angiogram revealed about 60 to 70% of stenosis of 2 major arteries. So he did medical treatment and still trained, keep running marathon, but he admitted he did not have a very good diet. About 5 years ago, he has symptoms again, and so the bypass was performed. They did the 3 bypass on him. So what should we advise for this man? Should he stop training or should he continue to run? So we all agree that physical inactivities is a known risk factors for heart disease. Moreover, we do know that sometimes more than normal training will benefit a lot. It is a very nice article on JCC published about 4 years ago. It says that training for first-time marathon will reverses your age-related aortic stiffness. So marathoners will have a more better aortic stiffness, and you can see the blood pressure will reduce with the marathon training. But it is safe to train if someone has a potential heart disease, such as coronary heart disease, because we do know that the cardiovascular event is different than other injury in the sport. The people, the athlete may die due to cardiovascular event. So first of all, we do know that we do have the guidelines tell us when to screen or how to screen professional athletes for cardiovascular diseases at risk of cardiac arrest. So if you have a patient with coronary heart disease, and before we advise them to keep on training or advise them not to train, we should stratify the risk of cardiac arrest on this patient. And the ESC has a very nice guideline about that. You can perform some exercise tests, perform the echo, the EKG, Holter EKG, cardiac MRI, CT angio, or EPS based on this individual risk stratification of this athlete. And we also need to notice that if the patient has some congenital coronary abnormalities, such as the ANCAPA or wrong sinus coronary, it is absolute contraindication for any exercise, and we do need to do the revascularization for this patient before we advise them to do any kind of exercise, no matter how hard the training will be. And so come back to the main topic here. We have a patient with chronic coronary syndrome, and it is a very beautiful article on JCC. They study patient with chronic stable heart disease, and they ask if the patient has physical activities or not. It is you can see they classify mild or moderate or vigorous exercise based on the questionnaire, and the result is that the least active population will have the highest risk of cardiovascular death, as well as MACE, myocardial infarction, and stroke. So the most active population will have the most reduction of on-cause mortality as well as cardiovascular death. And if you can see that, once again, it shows a very nice demonstration of those response, how much the patient should exercise. So the more the patient exercise, less the risk of mortality. And so you can see that the result of the article showing that for exercises in patients with stable coronary heart disease, the most beneficial group will be the highest risk group, the oldest one, the one with currently smoker, diabetes mellitus, people with peripheral artery disease, people with higher cardiac biomarkers like high troponin, proBNP, and high cholesterol. So the conclusion of this article is that for patients with chronic stable coronary artery disease, little exercise is good, but more is better, and vigorous is the best. But if the patient is training before he has coronary heart disease, and now he has established coronary heart disease, should he keep on training or should he change it? And it is a study on the European Heart Journal published in 2020. You can see that compared to other group, the group with decrease the training pattern from 5 times a week, they reduce to 3 times a week, or 1 or 2 times a week, or this reduction will end up with an increased risk of mortality. So it is very interesting result that normally when you see a patient with coronary heart disease, we advise them not to exercise, to stop training. But the result is that once they stop training or they just reduce their training program, the risk of cardiovascular event will increase compared to the group that they don't change their training habit or they increase their physical activities program. So the conclusion of this article show that if we change the frequency from moderate to vigorous physical activity, especially in people more than 60 years old, we can save up to 11% of reduction in terms of risk of cardiovascular disease, myocardial infarction, and stroke. On the other hand, if we decrease the frequency from 5 times to 3 or 2 or 1 times per week, we can increase up to 27% of risk of cardiovascular disease. There is a more recent systematic review published on GACC last year. They do the meta-analysis of 9 prospective cohorts, including more than 33,000 patients with coronary heart disease, and the patient was also asked using the physical activity questionnaire, and you can see the mild physical activities here will include easy walking, yoga, tai chi, or just mild housework. Moderate will be including fast walking, jogging, gardening, bicycling, dancing, or swimming. And vigorous exercise included running, lifting, or strenuous sport or strenuous work. Here you can see the summary of 9 cohort study included in the meta-analysis. And the result is that if we look at the first pattern here, the group that have active lifestyle over time will have a very low risk of mortality. In the group D, the people that increase activity over time, that means they started with low intensity of physical activity, and then they started to train, they started to do more and more physical activities. In this group also favor that more activity will be better over time. And in group C, you can see in people with decreased activity over time, the risk of mortality will increase. So the conclusion of this study is showing that in terms of all-cause mortality as well as cardiovascular mortality, if you keep your active lifestyle over time, or you increase your activity over time, of course, you can reduce your risk of mortality. That means that consistent active lifestyle is associated with the highest survival. On the other hand, if people have decreased activities over time, it is not a good sign for the long-term mortality. So people, even if they start with very low activity lifestyle, they can overcome this prior inactivity by becoming active later in life. And of course, we do know about some adaptation of coronary circulation to exercise training. There are several mechanisms about the correction of endothelial dysfunction, some more collaterals, regression of coronary stenosis, vasculogenesis, and platelet activation. And of course, we can assume that if you do the reverse thing, that we stop training or we reduce the intensity of physical activities, we will have the reverse result, that less blood flow, less luminal diameter of coronary. And it is some experimental showing that the more exercise, the more collateral blood flow by angiogenesis or arterialization of capillaries and microvessels, as well as will be lowering resistance of the collateral supply arteries. If you see that patient, it is some case studies published on Circulation quite a long time ago. Patient with myocardial infarction of the total occlusion of the LED, and you can see compared to the baseline, the exercise images about several weeks after the event, showing more collateral from the RCA to LED, and also on the scintigraphy, you can see some improvement in thallium uptake in the basal as well as mid anterolateral segment. So it can assume that exercise will facilitate the collateral flow to coronary arteries. Okay, so now we have the general consensus that we should keep physical activity over the life course, even for primary prevention. That means patient don't have any event yet, or even for secondary or tertiary prevention, that if the patient has some coronary artery disease or some stroke, they should keep on training or even increase their physical activity model. So what that the guideline says, we have some guidelines from the ESC. It is the ESC textbook of sport cardiology, showing that even if patient has documented coronary artery disease with high probability of exercise-induced adverse outcome, patient should have revascularization, and then he can be advised to do some sport, even competitive sport, after individual assessment. And active lifestyle should be maintained. And it is the same in the 2020 ESC guidelines on sport cardiology. So they have something called exercise prescription, that all patients with coronary artery disease asymptomatic should be doing some level of physical activities. And if the patient has a very high risk lesion, first of all, they should have revascularization of coronary artery disease. And after that, if the patient is asymptomatic, EF is good, no exercise-induced arrhythmias, so patient is advised to be participating in intensive exercise program, including some competitive sports. So back to our case study, Dave Mack was really he's a race director of the famous Boston Marathon. He has cabbage in 2018, and so should he stop and continue training? So based on the current guideline, current evidence, we know that if this guy previously very active man, if he stopped training, he may have some worse outcome in the future. So I think in this particular case, he is advised to keep on training based on a very careful and thorough assessment of the risks. So he keep on training. He participate in many intensive rehabilitation programs with mild to moderate exercise. And last year he finished his 50th time of the Boston Marathon, and you see the course here, 42 kilometers, and the course is quite hilly, but he can still complete it. So in conclusion, I can say that exercise is safe in patients with coronary artery disease, and as long as we don't see any evidence of exercise-induced ischemia. And patients with coronary heart disease may benefit by preserving or adopting an active lifestyle. On the other hand, past activity can be weakened or lost if physical activities is not maintained, and physical exercise trajectories may reduce long-term mortality in all individuals, especially patients with coronary heart disease. And for this patient, little exercise is good, more is even better. And the role of doctors is not only to give a patient a longer life, but also a better life. So thank you very much for your attention.
Thank you, Dr. Lin. Very nice that you are also a marathon runner. And I can figure why you raise this example. It's a very good example. They can still run Boston Marathon after receiving the bypass graft surgery. It's really amazing. Yeah, and I would like to ask, is there any question from the audience? No? If not, I have a question for Dr. Lim. Because you are also a interventionalist, and you say they can maintain their exercise. But how about for the case receiving standing? I mean, my question is, how long you would suggest they restore their exercise, such as high intensity exercise, after receiving a stent?
Okay. It is a very practical questions because I do have the same questions. So first of all, I think that the goal of giving a stent is not only to reduce cardiovascular death, but I think the goal of treatment is that we bring the normal life to the patient.
Yes.
Okay, so if the patient has very good training or active physical activities before the event, more or less, he wants to be the same before the event. But I think it's very important to perform a carefully stress test, I mean, exercise test, before we send the patient to any rehabilitation program. So normally I ask them to rest about 1 or 2 months after the event, and then they can start to do some physical activities again. And it is very important to make sure that he does not do anything that will cause ischemia. So normally, you know that as long as the patient can train and he can still talking during training, that means that it is a very normal training. It is not so hard training as there's no oxygen depth. I think he can train. So it is a very practical way for the patient to know how much should they train. If he run too fast and he can hardly talk during his run, that means there's some lacking of oxygen and it might cause some, ischemia. But if he do some swimming or might cycling, or just walking or yoga, and he can still talking during training like, okay, I'm feeling good, I'm feeling okay. So I think there's no evidence of ischemia during the training, so patient can keep on training. Yeah.
Thank you for your answer.
Mm.
Okay, I think it's time for us to move on to the next speaker.
Thank you so much.
Thank you, Dr. Ling, again. Let's move on to the next speaker. Let me introduce. She is a attending physician, also a cardiologist from Cardiovascular Center, Dr. Ho Li-ting from Taiwan, also and National Taiwan University Hospital. And her talk will be sports recommendation in hypertrophic cardiomyopathy, recreational and athletic exercise. Please, Dr. Ho.
Thank you. Okay, let me share my slide first. Thank you, Chairman. Ladies and gentlemen, I'm Dr. He Li-ting from National Taiwan University Hospital in Taiwan. Today, my topic is the sports recommendation in patients with hypertrophic cardiomyopathy. And I think that the exercise topic is quite hot in the recent few years. And there are some guidelines talk about the sports in patients with cardiovascular disease. So that's why here we have a afternoon seminar for this topic. And this is my disclosure. And I'm an electrophysiologist in my hospital. So I deal with patients with sudden cardiac death, VTVF. So we can know that there is a exercise paradox in general population. Like the former speaker said, that the exercise may improve the long-term outcome, but it also had immediate risk. And exercise can increase the risk of sudden cardiac death, but for a long time, the exercise may lower the lifetime risk of sudden cardiac death and mortality. So I think the net benefit for the general population is positive. So we encourage general population for the routinely daily exercise to improve their outcome. But the issue of the sport-related sudden cardiac death is still important. We can see that the general population, the overall sport-related cardiac death the incidence rate is around 4.6 per million per year. It is quite much more lower than the overall sudden cardiac risk in general population. The sudden cardiac risk in general population may be higher to 0.1% per year. And for the athlete, the risk is maybe twice higher than the general population. And if we see the general population, the most causes of the sport-related sudden cardiac risk is unexplained. And the second one is coronary artery disease. And as for the hypertrophic cardiomyopathy or the possible hypertrophic cardiomyopathy, it accounted for less than 5%. However, although there is lack of any outcomes data, in the old days in 1985, the US and the European consensus guideline against the vigorous recreational physical activity and ineligibility for sports participation for all patients with hypertrophic cardiomyopathy. However, because of the restriction from exercise, it will have some adverse consequences, including that these people may have higher prevalence of obesity, highlighted anxiety, and reduced emotional well-being. So in these patients, should we encourage them to have exercise? Is a question in the recent 20 or 30 years. And first, we'll see the exercise physiology in hypertrophic cardiomyopathy. The peak oxygen consumption, VO max, is substantially lower, maybe due to the diastolic dysfunction and LVOT obstruction. And also, the VO max and the VCO2 are independent predictors of the heart failure and cardiac transplantation, but not sudden cardiac death. And sometimes the patient with hypertrophic cardiomyopathy may have chronotropic incompetence. So in patient with HCM, they have less exercise capacity compared to the general population. And also the exercise may trigger the ventricular arrhythmia. The mechanism may be due to the elevated sympathetic drive, myocardial stretch, or the myocardial ischemia. Although in general, the increased sympathetic drive during exercise may consider to potential pro-arrhythmic, but the most majority of the sudden cardiac death in patients with hypertrophic cardiomyopathies may occur at rest during sleep or only minimal exercise. So we know the potential risk of exercise, including the arrhythmogeneity due to the myocyte disarray and fibrosis, or the catecholamine surge, and the volume shift may increase the LVOT obstruction and increase the risk of syncope, or increase the ischemia burden, or increase the myocardial oxygen supply demand mismatch. But also there are benefits of exercise, including that may increase vagal tone to decrease the ventricular arrhythmia, or decrease the endothelial dysfunction, increase the oxidative capacity, and increase the diastolic filling and stroke volume. So how about the net benefit of exercise in patients with hypertrophic cardiomyopathies? In 2015, there is a single-arm interventional study for the patient with HCM with exercise training. They included the patient with diagnosis of hypertrophic cardiomyopathy with functional class 2 to 4 and performed the exercise training maybe twice a week and one session for 60 minutes, and to compare their function. And we can see that before training, the patient may in functional class 2 or 3, and after training, the general condition, the functional status improved after the exercise training. And we can see the baseline exercise capacity may be around 4.7 METs, and after the training may increase to 7.2 METs. So after the training, the patient may have better functional class and better exercise capacity. And also, none of the patients experience clinical deterioration or significant adverse event. So it indicated that adequate intensity of exercise training may be beneficial in these patients. And in 2017, there is a RESET HCM randomized controlled trial, which included the hypertrophic cardiomyopathy patient by echo diagnosis without other possible causes, but excluded some high-risk patients, include the history of ventricular arrhythmia or high LVOT obstruction, pressure gradient, or history of hypotensive response after exercise, or functional class 4 heart failure, CCS class 4 angina, or low EF patient. And in this study, the exercise intensity is around moderate intensity. It is 6 minutes per session, 4 to 6 sessions per week, and increased gradually by the patient capacity. And it is much more intense than the previous one. And we can see that after the exercise, the peak oxygen consumption is higher in the exercise team than the usual activity. And there are still some ventricular arrhythmia or some adverse event in both groups, both in the usual activity group and exercise group. And rare patient may experience more severe non-sustained VT and have to stop the exercise, but most of the patient can tolerate the exercise training well and have the improved peak oxygen consumption from baseline. So as for the moderate intensity exercise, I think if we can, if the patient without the high risk factors of sudden cardiac death, such as that history or syncope history or ventricular arrhythmia history or hypotensive response with exercise testing, it is safe in these patients to have moderate intensity exercise. So, in the recent guideline, it is recommended in these patients. But how about the vigorous or the athlete? As we know that the risk of sudden cardiac death is much higher than the athletes. There is a 20-year study in National Collegiate Athletic Association, and they found that the sudden cardiac death risk is lower in the recent 20 years, but overall incidence may be around 15 per million per athlete year. And in these patients with sudden cardiac death, hypertrophic cardiomyopathy may account for 10 to 15% of the patients. And if we see that whether the sudden cardiac death is related to the exercise, in patients with cardiomyopathy, hypertrophic cardiomyopathy, only half the patient suffers from sudden cardiac death during exercise, and the other half is during non-exercise. So it is safe for these patients to have vigorous or athletic activity. In 2020, there is a population-based cohort study to figure out the association of the physical activity with all-cause mortality and CV mortality in patients with HCM. And they found that the moderate to vigorous intensity physical activity in the middle-aged population with HCM was associated with progressive reduction of all-cause and cardiovascular mortality. It means that the higher intensity may be more beneficial to the long-term outcome, even the patient have HCM. And in the recent 2023, there is a famous live HCM study. It is a prospective observational cohort study. And they included 8 to 60 years old patient with HCM diagnosis, even as overt HCM with phenotype positive or genotype positive and phenotype negative patient, and included any condition precluding vigorous exercise, such as advanced heart failure symptoms or LVH due to other diseases. And exercise intensity was categorized with non-vigorous and vigorous. And the non-vigorous also divided to sedentary or the moderate intensity. And in the vigorous group, the subgroup can divide it into non-competitive and competitive group. And we can compare the vigorous and non-vigorous group, and we can see that the outcome is similar. The composite endpoint in this study was death, cardiac arrest, appropriate ICD shock, and any arrhythmic syncope due to exercise or not. So the non-vigorous group and the vigorous group share the same composite endpoint incidence rate. And in the subgroup analysis, we can see that not related to the exercise intensity, no matter you are in the vigorous group or in the sedentary group, all exercise intensity will be share the same event rate. The event rate is around 15 per 1,000 per years. So I think that it is an important study to show us that even the patient have HCM, vigorous or non-vigorous exercise is good for these patients' long-term outcome and not increase the risk of sudden cardiac death. So for the vigorous or athletic exercise, if the patient is not in the high sudden cardiac risk group, and what is the high sudden cardiac risk group in HCM, including the age, the wall thickness, the LA size, LVOT gradient, family history of sudden cardiac death, past history of VT or unexplained syncope. If the patient is not in the high risk group, and I think that there is no higher risk compared with the moderate intensity and sedentary intensity exercise. But because the vigorous exercise or the athlete share the higher risk of sudden cardiac death, so these patients may have shared decision making with the physician to decide whether he can have vigorous or athletic exercise. So there is a recent guidelines to show us the suggestion of the exercise in patients with hypertrophic cardiomyopathy. In 2020, the ACC-AHA guideline told us that for most patients of HCM, mild to moderate intensity recreational exercise is beneficial to improve the fitness and functional and long-term outcome. And for athletes, if we have a comprehensive evaluation, I think that potential risk of sports participation is recommended. And in patients with overt HCM, maybe we have lower intensity to improve the long-term fitness, but not increase the sudden cardiac death risk. And if the positive is genotype positive, phenotype negative for hypertrophic cardiomyopathy, I think that competitive athletic exercise may be suitable for them, and it will be recommended. And if for a patient with high intensity recreational activity with high to moderate competitive sport, I think that we should have shared decision making in patients with overt HCM, and to have comprehensive evaluation every year to decide whether the sport can continue. And there is a class-free indication is that we play
I think we encounter some technical issue. So we have our staff can help that to restore the. Okay, before Dr. He comes back, I think.
Oh, nanti di
Okay.
di accept, Pak. Tunggu sebentar. Nanti di accept sama mereka. Kami telah memberitahu mereka bahwa Alex sudah masuk.
Do we still have Dr. He here? Thank you for everyone's patience.
Ini udah bawah.
Yes, Dr.
Okay,
Deep, what can I do for
Professor
you?
Lee, yeah, we wait for the Dr. Ho. I think that's
She
not in the
disconnected
Zoom.
accidentally. Yeah. She seems not in.
She is not here.
Yeah, not here. Only at
Yeah.
where there's a doctor.
Not here. It's okay.
Yeah,
All right. So do you have anything that we can exchange? Any opinion about today's talks? I think that Dr. He has done a very good job giving us a very comprehensive review about latest guidelines and studies, very important for hypertrophic cardiomyopathy. But if you notice that for this kind of study for HCM, most studies they excluded HCM with LV outflow tract obstruction. I think that's a very important issue that we should recognize that HCM actually is a very heterogeneous cardiomyopathy, that they have different genotype backgrounds. They may have a mixture of arrhythmogenicity. Some of them actually they don't have any problem of ventricular arrhythmia, and some of them may combine with say atrial myopathy, they are prone to atrial fibrillation. That would cause even the worsening of their exertional intolerance. So I think that's something we need to pay attention. Is there any comment from Dr. Ambari?
Yeah, I'm agree with you, Professor Lee. We wait for the Dr. Ho. I think it's the IPAC already made a guideline for the for the screening patients with a sudden cardiac death. We have young athlete screening, which is, I think that's very important for us to screen patients with cardiomyopathy, especially to prevent the myocardial death. And then I think it's very important we try to looking for the family tree and history for the patients. And then after that, maybe ACG is very simple to try to diagnose patients with the cardiomyopathy, especially in this case. Maybe I have a question from Dr. Lin. I think that's we have a time for discussion, Professor Lin.
Okay.
It is, Dr. Lin, it's very interesting. We have a lot of patients after KBH and then after especially acute coronary
喂，何医师
syndromes.
哈，
Yeah.
哎，你那边网络是不是有什么问题？因为我们会议没有断嘞，我们会议是还在好的，是不是网络你就关掉了？这奇怪。
Okay.
真的
Is that
现在我看
from
庄
the
志明
acute
上来了，我有看到他在上面，你没有你，但是他现在他进来了，他在里面，他现在在里面，但是你，那要不要我要跟那个主席讲一下吗？我还是怎么？就他们有在 discuss， 他们还在 discussion 关于你的题目。好 ，OK， 奇怪了，因为好没关系，那我来处理，我来跟他们讲哈 ，OK。Beg your pardon, Dr. Ho, she said she have a problem to connect the system again. So Dr. Zhuang Ziming, also from her colleague, maybe can answer some question if you do have it.
Yeah, it's fine. We have some panel discussion with Dr. Lim is answering to Dr. Ambari's question. Okay, please go ahead.
Okay, thank you very much, Professor Lee. I would like to ask you, Dr. Lin, for the patients after, especially athlete who which is with the acute coronary syndromes, is it the timing for the back to the your case is stated that after KBs and a couple of years later after cardiac rehabilitation they can perform a exercise, but mostly in our patients, especially in acute coronary syndrome patients, or if you're not mistaken, there is an athlete which is a football player Ericsson, with ICD, and then in one country they don't allow the athletes to perform a high intensity exercise, especially competitive exercise. Is that maybe from your opinion, actually, patients, especially after ICD, it is allowed for them to join the competitive, like a football or the other things in a high intensity training?
Okay, thank you for your questions. Of course, I do know about the case of the footballer Christiansen, and I do know that he has come back to the highest, that legal to play football at the highest level. I don't think that there's any contraindication for athlete with the ICD to come back, because that the ICD is very protective now, and if you rule out all other causes that might cause sudden cardiac arrest, I think it is safe for this individual to go back to their competitive sport training before. The problem is that not every athlete will have ICD. But I do think that if the patient has ICD already, I think it is safe to be back to sport. What is your opinion?
Yeah, that's very interesting, Professor Lee. Maybe you have a opinion about this one because some experts said cannot do, and
For
then
those, yes, for those sports regulation, if that's ICD is not prohibited in the field, I think that's okay. And I think you also noticed one of Dr. He's presentation, the slide showing that the idea of shared decision making, I think the shared decision making is also a key for those athletes with competitive sports.
yes, thank you very much, Professor Lee.
As any ICD or they are a rescue after a heart attack or something like that. I think that's also a very important idea.
So,
Yes, thank you very much.
Dr. Ambari, may I ask you questions about the
Yes.
master heart study?
Yeah.
So far they don't see any relation about the cardiovascular outcomes in the both two groups. You just see the coronary plaque. But is there any other trial showing that there's an worse adverse outcomes in the group with very vigorous exercises?
Yes, thank you very much, Dr. Lynch. I think the good news is that the principal investigator continue this this study till 2 years again. I mean, in France, of course, that they want to know about the survival of the patients, maybe because this one of the limitation of this study. They just only try to looking for the relations between the intensity, especially in long life athletes, and then with the non-athletes. But of course, in this study, they don't talk about the survival, about the decrease the mortality or cardiovascular risk. But we wait till 2 years after this study, and then they will maybe have new publications about what you question about the survival of the patients. But the other things that's very important is that moderate intensity. The point is, I think that moderate intensity exercise training give a lot of benefit than vigorous exercise training, especially in athletes. Yeah, maybe that's my answer. Thank you very much, Dr. Lee.
Thank you.
I think Professor Lin.
Yes.
I think this is the end of our session, isn't it? Maybe Professor Lee, you can close the session.
Today's program, and I think so. And I would like to, maybe before we leave the webinar, could you just turn on your camera? Maybe we can have a photo, a good photo before we leave the meeting. I would like to invite everyone, even the audience. So you are ready. Who will take the photo for us?
Yeah, I will take photo. So everybody turn on your camera so we can have a group photo. Thank you.
Can have a good photo.
Okay, great.
Okay, Professor Lin. Okay, 1, 2, 3. Done. Thank you.
Thank you for your
Yeah.
chairmanship.
Dr. Herb.
Is that her?
Dr. Ho, she just connect with her
What's
mobile
name?
phone.
Okay, Dr. Please, Professor Lin.
Okay. Okay, Dr. Ho is back. So you want to take photo again?
Just,
Okay.
Okay.
We'll take one more photo.
yes, I will take one more. Thank you. Okay, done. Doctor.
Thank you.
Yeah,
Thank you so much.
okay.
Okay.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Thank you.
Okay. Thank you very much. See you for
Thank
the
you, thank
next
you.
webinar of APC. Thank you very
Thank
much.
you.
See you.
Thank you.
Thank you.